We're delighted to welcome you to the webinar today, which is on healthcare affordability and untangling the cost drivers. We know that some of you are a little bit more familiar with this work than others, but we're going to take it from the top. Our hope is to explain the highlights from the brand new benchmark report that was released across the country this month. And we're going to talk a little bit about the overview, why it's important, show you the highlight findings from the report itself, and talk a bit about what the takeaways are and some of the next steps for the project. So I'm joined by my colleagues who've actually been responsible for this amazing work. I know we actually have community members who are on the phone who've also contributed to this work in different ways over the history of this project. And we're going to try to go through the slide deck fairly quickly and leave lots of opportunity for questions for those of you who have joined us. And there are two ways that you can do that. Megan has everybody on mute. But while we're doing the presentation, feel free to use the chat function, which is at the bottom of your screen. You can type in any questions, and you can also ask them directly at the end of the program when we all open up the mics and allow for questions. So with that, I think we'll go ahead and get started with the first slide. I think one of the things that's always important in this work is to remember why we do it and why it's important. There are a series of quotes that are here, and I think some of them were featured in the national rollout last week, but they just put it in a really fine context. Between 2006 and 2016, the average premium contribution paid by U.S. families with employer-sponsored health insurance increased by 77%. During that same time frame, the median household income rose by just below 19%. The Kaiser Family Foundation has reported that by 2030, Medicare beneficiaries are likely to pay half of their average Social Security income for out-of-pocket healthcare costs. And with 30% of healthcare services deemed low value or waste, there is ample opportunity to bring down the cost of healthcare without reducing or compromising patient care. On the next slide, you might remember that for Oregon and for QCOR and HealthInsight, this has been a long journey. It was in 2012 when the board actually prioritized and acknowledged their belief that adding cost to the quality and utilization measures that were available in Oregon was really important. The board also decided to use the last round of the Aligning Forces for Quality grant that we had to get ready for what was next. And then we were really fortunate because the Network for Regional Healthcare Improvement, or NRHI, which is our national organization, also secured funding, which was really about standardizing the approach to measurement of the total cost of care. I think Oregon is even more unique. Some of you who are on the call are aware or have participated as members in a 21-member advisory committee that's been with us for this journey. That group has met almost every month over the last several years to help guide and advise the staff, both on the benchmark report, but also on the primary care clinic reports that we've distributed over the last several years. Just to give you a sense of the impact of this work, the benchmark report that we're about to talk about has 5 states that are highlighted, and we'll talk about those more in a moment. Colorado, Maine, and Minnesota and Oregon and Massachusetts are involved in this year's report. And then the blue states that are here that are shown across the map are other NRHI members who are in some phase of development to follow in the footsteps of the pioneers and to contribute in their own unique ways to this body of work that's taking place across the country. So we're really excited. We're really grateful to Robert Wood Johnson for the funding to do this, and our partners at Health Partners who've given us the opportunity to use the measurement tool that rolls up to create this benchmark report. So on the next slide, here is just a reminder that this report that we're talking about today is actually the second Last year, the groundbreaking first report actually highlighted for one of the first times how states are doing across the board. And you'll remember that in Oregon, we got some particular attention among stakeholders because although we were doing relatively well in the utilization of health services, we were an outlier as it related to price. And we'll talk a little bit more about that in the second report. So if we go to the next slide, again, here are the different states. And in a minute, I'm going to turn it over to my colleague, Doug, so that he can talk a little bit about the finding across the United States. What I would like to just stress for Oregon is that we really believe that this benchmark report, coupled with the clinic reports that we have been distributing and are getting ready to update here in the next couple weeks, really for the first time provide all stakeholders with a new compass and a new tool set to be able to look at how we're doing compared to other states nationally, but also regionally allow us to use these clinic reports to really see how we're doing across the state, both geographically, by systems of care, by providers of care. And we really believe that those things combined give us a really good chance at making a difference in our community. So one of the things that this report will tell you, and I'd encourage you to read it if you haven't, is just all the different ways that stakeholders are using this information. So many of you may know in Oregon, the primary care clinics that have gotten the reports on both the adult and pediatric population have really been using these early findings to help look at places in which there can be improvements. And we've looked at the variation across the state of Oregon, and it's still significant and has lots of opportunity for improvement. We know in Oregon that the policymakers really were interested in this information. Meredith and Doug had the opportunity to testify several times last year in front of the legislature about these findings. We also know that health plans are interested, and we work with partners in health plans to look at this information and see how it can supplement and add to information that's being provided by plans across Oregon. And I think also purchasers, we're hoping to interest and engage them more in this conversation to take a look at this the important findings that are here. So it's not just one stakeholder, but what we're really hoping is that this information gives us some regional direction on how we can improve together. And that's one of the backbone tenets of regional health improvement collaboratives, is to bring partners together to use this information. So with that, I'm going to turn it over to Doug Rupp, who's going to take us through some of the important facts and learning.
Great. Thank you, Mylea. I'll go over some of the findings from this benchmark report. I just would like to do an overview of the difference between the two benchmark reports. Last year, as Mylea mentioned, we had Midwest Health Initiative, which is based in St. Louis, primarily the St. Louis metropolitan area, included in the benchmark. They were unable to get to the point where they felt their data was of the quality that we needed for this year's benchmark report, so they're no longer in here. Colorado, who had some data issues last year, was able to participate. And I think the differences between those two areas is something, or those two regions, one leaving and a new one coming in, is something that I want to go into a little bit. So looking at the data for this year's report, we see, starting on the East Coast, Maryland showing prices that are 16% below this 5-state average. Maryland and Colorado are both above, with Colorado being the highest at 17% on overall costs. Utah's a little bit below, and Oregon shows up as being very much on par with the 5-state average. On the next slide, we can see a little bit more about how those costs break out. If we look, Colorado again is the highest in price, and these bar charts correspond to those percentages that were on the map on the previous slide, with Colorado showing quite a bit above the average. And On these bar charts, it's broken out into the two components that these total cost of care measures let us see. There's the price component in green and then the resource use component in blue. And specifically for Colorado, we see that about 6% of the cost can be attributed to prices, with a larger percentage, around 11%, being attributed to the resources provided to those patients. Minnesota is directionally the same, but to a lesser extent, with both price and resources contributing to the overall costs. Maryland is, again, the lowest in overall total cost, and a lot of that is driven by lower prices in the state. Then we get to Oregon, and Oregon looks different from these other charts in that part of the box is above and part of it is below. And this is how Oregon's costs cancel out to average. So the green box showing price, Oregon is considerably higher than the average. And the blue box showing resource use, we're considerably lower. So what this is telling us is that we do use fewer resources, but any savings we would get from those fewer resources that are being used are being compensated or being offset by higher prices on average that we're paying in the state. And then the final box here is Utah, where they have a small price difference to the average of being lower, and then a slightly higher resource use. I want to note the data that we're using here is 2015 claims data, and so that's what we've used for this benchmark. I think most of you know we are working very hard on getting the clinic comparison reports out, and those will be based on the 2016 data. We've had a couple more delays, but I'm hoping to get them out as soon as possible. But I wanted to let you know that this is 2015 data that we're looking at here. If we drill down a little bit further into the measures, we can look specifically at Oregon and see where how costs are being driven. And I think last year the report got a lot of interest because Oregon showed high in price, and again this time around we're showing high in price as well. If you look down at the bottom of the chart on the right under price, Oregon shows inpatient of 16%, outpatient 11%, and professional is 15% higher than the 5-state average. And those are all either matching or higher than any of the other states. So we really are seeing in the data that we're looking at higher prices in Oregon. And again, you can see the resource use here where Oregon is showing lower resource use, particularly in facility, inpatient, and outpatient, as well as pharmacy. On the next slide, you can see we have, this is from the prior benchmark report, but I think it's a really important slide. This really shows what the particular drivers are that affect, on the left side, price, and on the right side, that utilization or resource use. We know that provider market power, or whether health plans have a lot of market power, affects the overall price. There's some conflict over whether cost shifting between Medicare, Medicaid, and commercial are having an effect on overall price. But in this study, we do know that as far as Medicare goes, Maryland is the lowest is the highest at reimbursement rates, and Oregon is the lowest. And there is somewhat of a consistency there. So the jury's out on whether cost shifting is actually an effect on overall price. We know that regional cost of living, where Oregon is higher, can have an effect, but Maryland is actually higher in cost of living and has lower healthcare costs. And then location of service, and by this we mean whether the services are provided in a facility where just overall costs are higher, or whether they're a freestanding type of place. And then utilization, obviously, the patient morbidity, how physicians learn to doctor, and any changes they've made to how they provide services. And there's also an effect of how much patients pay. We know in the St. Louis metro area, they have a lot of high deductible health plans where that may be holding down utilization. State mandates and then also provider networks can have an effect on that utilization side. And I'll turn it over to Meredith, who can, that was just a quick overview of the report, but we want to hear what you've seen or what questions you have. I'll turn it over to Meredith.
Thanks, Doug. So before I start with the canned questions, I thought I'd pause and see if anyone had any immediate questions about the data or any initial thoughts that came to them while we were reviewing the numbers. Michael, I know you have a comment. All right, not hearing any. So kind of the first question I often get when reviewing this kind of information is, what was most surprising to the team here, who's been looking at the data for quite some time? And for me, the most surprising finding is, I guess not surprising, but most relevant is, although the numbers have changed from last year, they are consistent. So we were happy to see that the story didn't completely change in Oregon. We were low in resource use last year, and we're high in price. And the same story applies this year. So it actually is showing some validity over time. And for a lot of the other states, this is true as well. So this is not a fluke. It's not just the one way we're looking at our data. We're seeing consistency over time, which really can help us start answering some of those questions about why prices are higher, what might be driving these prices. So I don't know if Mylea or Doug wants to reflect on what was most surprising to them.
So this is Mylea, and if Megan backs up to the takeaway slide, the one that actually has, I think it's the 3 slides, right? No, the next one.
Yeah.
I mean, I think the points here, in discussions, especially as we were discussing across the findings with the various states, you know, it is complicated, and I think we kind of chuckle when we put this on here. But I think to Doug's point, that that you just look at these findings and you realize that there isn't one size fits all solution in any of these markets for those of us that are working on it. And so a lot of people want to say it is just about waste in the system or overutilization. Other people want to say price. Well, in all of these variables, you know, those things are at play, but they're at play at really different levels. I think, you know, when I look at Maryland, clearly, you know, Oregon was the outlier last year in terms of price, but, you know, if you look at the upside and you look at Maryland, and you kind of look at their risk score and kind of their overall total cost of care, I do think that, you know, the opportunity is for all of us to be studying, you know, what is working, but what is working in different ways too across these states. So those would be the ones I would add.
I think that's a great point, Mylea, and it kind of underscores what NRHI often talks about. You know, data can help us answer questions, but it's really about what's happening at the ground level in each location. So what might work in Oregon might be, you know, disastrous in Maryland, and vice versa. And I think part of the power of this kind of report and this kind of collaborative we build across the country is we can share those ideas. We can test them with our stakeholders to see what sticks and what might not fly in Oregon, and that's okay.
And if I can ask Megan, do you have that slide available on trending? Thanks for flipping around. I just wanted to talk a little bit to Meredith's point about consistency. And we had one region drop out, which happened to be the lowest price region. And we had one region added, which ended up being the highest price region. Colorado came in and St. Louis went out. And in the report is a chart showing the different, the 4 states that are consistent in both reports. And I think this gets to the level that Meredith was talking about. In the first benchmark report, Oregon was 7% higher than the average of these 4 regions, and 4% higher in the 2015 of the average of the same 4 regions. So given that there were other changes, the populations changed a little bit based on no longer allowing with some of the states don't have the self-funded plans anymore. There is consistency in the ranking and overall consistency in the place that folks are.
I noticed that we have Rita on the phone, who actually works for our affiliate in Utah, and their findings were quite different than ours. I find it fascinating that your inpatient resource utilization is so high in Utah, Rita. Do you mind commenting on that?
Well, as you know, Utah has the highest birth rate in the country. It's basically inpatient utilization that drives us a little bit higher. Luckily, our prices are lower. I think 14% lower than the group average. But otherwise, you'd see quite a spike because of our high birth rate. I mean, it's like 5 or 6% higher than the national average.
But I think that's a perfect example that, you know, what might be a solution in Utah could not address Oregon's problem at all. So I think that's the power of this report, really drilling down into those numbers to see where the trends are over time.
And basically, I think it's also seeing where there's variation that's explainable, very easily explainable, and so looking for places where that variation isn't explainable is probably the way that we can find opportunities for positive change.
Thanks, Rita. So I'm curious from the people on the phone, it sounds like we have a pretty quiet group today, but I would hope that we could talk a little bit about what kinds of questions this report leads you to ask. What other slices of information might be useful in understanding kind of the story behind what's happening in Oregon?
Meredith, I have a question. Have you been able to do any deeper dives to see if the higher prices are concentrated in one area or another? I know that we've pretty much figured out that pharmacy is not different across these 5 states, but have you looked into anything else to try to identify maybe there's some area?
We do, and we suspected and had it verified that the rural areas are more expensive, and there are reasons for that. The amount of just in order to keep the machines running, there are additional costs. But we also found that in the smaller metropolitan areas, prices are also higher than in the Portland metro area, and we may be seeing some market power there with having only one hospital system in a particular area that may be able to negotiate better with the fairly large number of health plans that we have. So we are seeing that, although there are definitely exceptions we're finding here and there. So we do still see variation even within the smaller metro areas, within the rural areas, and within the Portland metro.
Thanks.
Does anyone else have comments or questions?
This is Michael. I was just going to ask if at the NRHI level, you will be breaking down kind of in that regional question of, there's a reason that rural costs are different than large metropolitan areas. So at the NRHI level, it's almost like taking each state and breaking it into rural versus medium urban versus large metro, because the cost structure for hospital in both inpatient and outpatient is different based on volumes in those different locales. It'd be nice to kind of look at that across the NRHI level.
I think that's a great idea, and Mylea is actually heading a new group at NRHI that's focused on affordability and kind of what's next. And I would hope that she would take that feedback back to NRHI. Thank you, Michael.
We also have a question in the chat from Patty. Does medical errors influence driving prices higher? And thank you, Doug, for addressing rural and urban differences.
Certainly. So that's a really good question about medical errors. And to the extent that they are errors that are reflected in the prices, in what's paid by the patient and the health plan, they would show up here. But we don't have a way with the claims data, a good way, we don't, of identifying what those costs are and how much they're affecting the overall cost.
Any other questions or comments or things you think we should look into?
Meredith, hi, this is Rita. I just have a comment. In another project, the Unite Teen project, we have looked within our states at metro and rural areas. And so just in reference to Michael's question, Doug, that might be something he'd like to look at.
We can certainly send that back out. Thank you. All right. I'll open it up one more time for questions at the end, but, oh, Patty, will these slides be available for us to share? Absolutely, we will send them out to everyone on the phone today. Thanks, Patty. So, Megan, if you could advance the slide just once. So I'm sure many of you are wondering what's next, and we put together this slide just to do a quick review of where we've been over the last few years. It definitely feels like going down memory lane, considering Doug and I met for the first time in Austin, Texas, when we were rolling out this project back in 2013. So we've done a lot in the past 4 years, but I wanted to highlight where we're going next. So obviously the second benchmark report just came out. Doug is really hard at work getting those 2016 commercial clinic comparison reports released. They're going to be sent to about 200 primary care clinics this go around. We're really excited that we're moving ahead with this work. And for the first time, we're actually going to be showing a quality composite along with the cost information in those reports. So that's pretty exciting. Later this spring or summer, we will be releasing public reports for the first time. These will be very simple as a first go around to give a resource to patients out there who might want to see how their clinic is doing in overall cost and quality. Very frequently we get the question, what about Medicare? What about Medicaid? I'm happy to say that in the first half of this year, we will be producing on a large scale for the first time a Medicare fee-for-service clinic comparison report to about 75 clinics around the state. And then we are actively working on a pilot to address the feasibility of using the same type of report with the Medicaid population. So it's going to be a very, very busy 2018 for us. We're really happy that Utah, which is another HealthInsight state, has been along with us for most of this journey. And we're really looking forward to helping other HealthInsight states to figure out how they can do some level of reporting in their own communities. Next slide. And I just talked about most of this, but really we are really looking at costs from a number of different angles. And obviously healthcare costs are a big topic of conversation, both at the national and statewide level. And we're really trying to figure out how the rich database we have can help stakeholders answer the most pressing questions they have. So on this slide, there are just a few examples of what we plan to do. One of the most exciting things on this slide is on the bottom, and we actually got a little bit of additional funding from NRHI to really do a deep dive with a group of primary care clinics to say, okay, you have the base cost care information, but what else would help you to address where you might be an outlier, where you'd like to do better? So we're actively working with that group of clinics to really get to the next level of information to make sure it's as actionable as possible. So with that, I will pause one more time for questions.
This is Michael.
Hi, Michael.
A question for Doug. As the reports come out for the medical groups here very shortly, will you be, I was really encouraged to see the 2014 reports versus the 2015 reports, the consistency across the state level. Will we be able to see that comparative data on their new reports coming out for the clinic level, 14 versus 15?
Well, I think, as you know, the first version of the reports that we're coming out with is the 2016 data. So if you can hold tight until we release the 2015 data, then we'll have those comparisons.
Oh, so we will be able to see 14 versus 15 versus 16 for our groups.
Absolutely.
Yes.
Oh, I like yes answers.
It's hard to say no to you, Michael. All right. So with that, I'd like to thank all of you for attending today.
Meredith?
Yeah.
One more question.
Sure.
So, you know, as this data starts to become public, there's just a lot of pieces to why is Oregon better in utilization? Why is Oregon more costly? Any work can be developed on how to relay this multifaceted question to the public?
Great question, Michael. So as a part of the Cost of Care Steering Committee, you'll remember that the committee agreed to showing some very basic information to the public. But we know that the primary audience for that website will be people like you and me who are wonks. Not that we don't want this in the public's hands, we certainly do. So we've gotten some preliminary feedback from communications folks about the best way to share this with the public. But I completely agree with you that this is really, really complicated stuff. And just in the communications about the benchmark report, you know, some of our folks and who are professional communication staff really encourage us to you know, make it as uncomplicated as possible. And it's hard for us sometimes to do that, being so deep in the information. So I would love your feedback along the way about how to make this more meaningful to the public.
And I wasn't so much thinking just about the website, but I was thinking more in the news release arena, where we want maybe public reporting to pick this up and start the dialogue about why are our costs higher.
Yep. Yeah, and Miley has been on a bunch of press calls in the past week, and I think there is some interest. I'm hopeful that that even though we're in a shortened legislative session right now, that this report has gotten into the right hands as a legislature, and increasing awareness in that way, and some of the task forces going on right now. I think it'll help us get the word out.
So Michael, this is Mylea, just to make sure that we're understanding. So I think what I heard you say is, you know, as these public reports roll out, you would actually be welcoming a similar kind of strategy for us to craft messages that would talk about the potential variation that we're going to see in the rollout of those measures, and make sure that folks are prepared to be able to answer questions from consumers and other stakeholders. Is that what you were saying?
Yeah, I think the value of this data is the transparency it allows, and then the real power is the dialogue that starts after that transparency within the public. To release it and have no discussion is not what I would desire.
Yeah, got it. And I also think, to Meredith's earlier point, this NRHI affordability campaign is the board of directors for NRHI several months ago got together, and unlike some of the work that we have discussed, which is more targeted at folks who are actually working inside of the healthcare system, I think the affordability campaign will have a much broader reach about, you know, why people should care and what it means to the individuals. And I think there'd be some good ways for us to kind of tie the big picture and the individual results. And I think it's different when we're explaining to citizens and patients and other stakeholders why will there be the variation we're going to see in that public release. So it's a really good point, Michael. All right. Meredith, anything else left on the list here?
I would just like to thank everyone for attending today. I'd encourage you to keep in touch and follow up with any questions or comments. Those of you who are on the Cost of Care Steering Committee, we will be having a very similar discussion tomorrow. So come prepared with the questions you asked today and more. And we're really excited to have you along this journey. It's been a lot of fun, and we couldn't have done it without you. So thank you very much.
Thank you.